Real quick, down and dirty on our endocrine emergencies, we're going to talk about them. They are relatively rare, but if you ever see them, I still kind of want you to have an idea of what could be going on. So adrenal insufficiency or Addison's disease, right? Decreased glucocorticoids and decreased mineral corticoids. So these are going to be our tiny, skinny little patients, right? Hypoglycemic, hyperkalemic because of that aldosterone dysfunction. Hyponatremia, again, because of that aldosterone dysfunction. So we're not making enough aldosterone. We're going to retain sodium, and then we're going to excrete more fluid and excrete more sodium with it. Okay, dehydrated, fatigued. These patients are going to have that bronze pigmentation of their skin because of the excess ACTH or adrenocorticotropic hormone actually changes the way our melanocytes work, hence the bronze skin. Postural hypotension because of the hypovolemia. GI disturbances, weakness, that's Addison. Okay, treat it with steroids. Gonna replace our glucocorticoids and our mineral corticoids. But now adrenal crisis. So adrenal crisis is when we have significant inadequate amounts of glucocorticoids, mineral corticoids, and adrenal hormones. Okay, so this can be either central, which is going to be our pituitary dysfunction. So we have a limited amount of ACTH. Okay, so no stimulation of the adrenal glands, or our adrenals themselves are not working. So things that can cause that are certain tumors, radiation, surgeries, right? If we remove a kidney, we take the adrenal gland with it. Or if we're not perfusing our adrenal glands. So renal artery stenosis can result in an adrenal crisis. Okay. And if we think about some of those things, right, our glucocorticoids, those are going to help regulate our blood sugar. So these patients will be severely hypoglycemic. Okay, mineral corticoids is going to be our fluid status and our salts. So low sodium, low fluid volume, so hypovolemic, and then hyperkalemic. So increases risks of arrhythmias, with also some cardiac collapse because of the hypovolemia. And then our adrenal hormones, so like adrenaline, okay, so epinephrine, norepinephrine, we're not going to have those being created. So we're not having vasoconstriction like we should in response to the hypovolemia. All right, and so that's going to cause vascular collapse. And that is where we have adrenal crisis. So vascular collapse and hypoglycemia. So we're not perfusing, and even if we are perfusing, we're not giving anything any energy to function. Okay. So what we're gonna do, nurses, right? We're checking blood sugars every hour on these patients. They're on the cardiac monitor, and then what we can expect is steroids and high dose steroids. So we're gonna give these guys hydrocortisone up to 200 milligrams a day. Sometimes we'll bolus them with like 100 at first, right? Vasopressors, so we can give epinephrine, norepinephrine to replace those hormones our adrenals aren't making. Fluids, lots of fluids. We got to fluid replace these guys. Monitoring that sodium. We'll fluid replace first and then assess if we need to replace our sodium. And that's adrenal crisis. And then prevention. Finding the cause, right? Seeing if this is pituitary problem, adrenal problem, and addressing from there. Real quick, down and dirty, Cushing's disease can be caused by long-term steroid use. Cushing's disease it's going to look kind of like the opposite of Addison. So we're going to have hyperglycemic all the time. So we're going to have to be overweight, fluid retention, hypokalemia, hyperaldosteronism. So we can see hypertension. Okay, they're going to have the gynecomastia, because we also have an increase in some of our adrenergic hormones, the buffalo hump, moon face, osteoporosis. That's Cushing's real quick. Okay, so mixed with our thyroid problems, thyroid problems here. So our myxedema coma, is myxedema coma, rarely it causes coma. Okay, we don't see this very often. But we're going to have severe hypothyroidism. So patients often have like a long-standing hypothyroidism that either hasn't been treated at all or isn't being adequately treated. They needed a dose adjustment. It didn't happen. They're not taking their medications appropriately. They're taking them the wrong time. They're taking them with food. They're taking them with other medications. We can even see it after like a big cold exposure. So anything that's going to have like an increased metabolic demand that kind of uses up all available T3 and T4. And then our thyroid can't replete those. And so patients will have been like lethargic for months before having the myxedema. And myxedema has a pretty poor prognosis. 20 to 50% of these cases end in mortality. And so what we're going to see is, for labs, we're going to see a low T4, high TSH. Okay, low T4 because our thyroid isn't making any, and then high TSH because our body's trying to stimulate that thyroid, but it's not. So this myxedema is going to be edema that it's non-pitting in the face and periorbital area, so up around their eyes, can be into their neck a little bit as well. Hypothermia, okay, you need a lot. Regulating your body temperature requires a lot of metabolic demand. Okay, it takes a lot of metabolism to regulate our body temperature, and we're not able to meet the metabolic demand. We're going to be cold, so we're getting core temperatures on these patients. Right, altered mental status, they're going to be lethargic, maybe a little confused. Again, rare. Coma, if it happens, we're not doing great. Hypoventilation. Okay, so hypoventilation is going to be problematic, so this might require intubation, bradycardia, reduced cardiac output, which is going to cause hypotension. All right, hyponatremia, decreased GFR, so decreased renal function, delayed deep tendon, reflexes. And then the myxedema is a result of mucin being accumulated, which is a substance that absorbs water, right? And so because we have, or we're lacking the ability to, and so mucin is a hormone that is very dependent on T3. And so lacking that hormone, we're not able to move fluid efficiently, and it's going to kind of build up in our periorbital face area. Again, so we're going to expect thyroid replacement. We can give levothyroxine IV, okay, and then supportive measures. So that's going to be rewarming, intubation. We don't want to give vasopressors necessarily. Our body has tried to respond with adrenergic hormones, right? So our epinephrine, norepinephrine, we're maxed out. Okay, those hormones are there, but there is not the T3 and T4 available for the muscles to contract. We can do dopamine to maybe help the inotropic function of the heart, but really we need to give that levothyroxine, and again, we can give it IV. And then managing their glucose. Again, it's not a fluid problem, so we can give albumin to help with hypotension. We don't necessarily want to give them fluid because they're going to have symptoms of, they can have symptoms of like CHF because their cardiac output is low. And so thyroid storm is the opposite. So myxedema coma, we think Hashimoto's. Thyroid storm, we think like Graves' disease. Anyways, thyroid storm is too much T3 and T4, right? And our body stores a little bit of the extra in our thyroid, a little bit. But if it's there, we're going to use it. All right, it's like, it's here. Obviously, there's some sort of metabolic demand. Let's do this. Though, in tests, our T3 and T4 might be low because it's all bound and causing problems, right? We're using it. And so I've bolded the symptoms that are part of like our thyroid storm criteria. So delirium and agitation, so changes in our level of consciousness, right? Restlessness, they might be like in psychosis, okay, hallucinating, all those things, because we have increased brain function, but not necessarily in a way that's helpful. Symptoms of congestive heart failure, and that's just because we've been tachycardic and hypertensive for a couple of days, all right, so much so that our heart can't keep up anymore, and it's starting to fail. Respiratory distress, fever, and these are high fevers. Okay, these are fevers greater than 100.4 is on this little sign, but we're going to see these guys like at 103, 104, 105, right? Cooking that little brain. They can be an AFib. We'll often see AFib is one of the first one of the first signs of thyroid storm or thyroid toxosis. Okay, and so thyroid toxosis is when we have the elevated T3, T4 plus some sort of CNS manifestation, okay, or one other symptom. And again, if we have all of these, then we are definitely in thyroid storm. So this is acute, life-threatening. It's going to be an exacerbation of thyroid toxosis, often occurring after some sort of infection or non-adherence to our medications, like our PTU or our tapazole, which PTU is kind of hard to take, so don't blame them. Or our tapazole is kind of hard to take. It's 3 times a day, so I don't blame them. But those can be causes. And so what we're going to do is beta blockers, right? We're going to reduce our heart rate. We're going to decrease our blood pressure. We're going to reduce our cardiac demand, decreasing our cardiac workload. We're going to give medication. So PTU is preferred because we can give it IV. So methimazole works quicker. PTU is going to work well when we give it IV. We can actually also give high levels of iodide. Okay, iodide is the oxidized form of iodine. Okay, it's what we need for thyroid synthesis. And sometimes if we give a lot of iodide, our body's like, oh, we're good. We don't need more T3, T4. We'll stop making and converting and synthesizing T3, which is the usable hormone. It doesn't work for very long, but it can kind of help slow that synthesis until our other medications start working, or we can radiate or get rid of the thyroid. And then again, symptom management. Okay, we're going to give steroids because thyroid storm is going to reduce our adrenal function, right? These guys might require dialysis or even like a plasmapheresis to help remove any excess T4. Okay, rest, we want to decrease our metabolic demand because we want to not make our body make more. So rest, maybe even sedation, and then just supportive measures. This, again, is pretty critical. These patients, they don't have great outcomes. So fluid, electrolytes, nutritional support, cooling measures if they're super hot. I mean, we can do an antipyretic, but it's probably not going to be as helpful as like ice in the armpits, alcohol baths, those types of things. So again, it's just a quick down and dirty of our